Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
So vitiligo. This is a friendly audience. I'm kind of preaching to the choir, but as you guys all know, roughly 1% incidence across the whole world, on the same order of psoriasis, right? So this is not a rare condition, and significant source of social and psychological stress, significant source of patient burden and disease burden to those of our patients who have it. And it's one of the oldest diseases known in humanity. Recorded in the ancient pre-Hindu Vedic literature as well as Egyptian papyri. This is a copy of the Ebers Papyrus from 1500 BCE describing it, right? But it's not until now that we've really moved beyond the old school recommendations of drink some sorolins containing teas and poultices and go sit out in the sun. Now we have targeted therapies for vitiligo and a long pipeline of new exciting therapies on their way. So let's talk about the bad news first, right? Vitiligo exists in this place where we suffer from this idea that vitiligo is a cosmetic condition. And so when we reach out to our payers, when we reach out to insurance companies, when we reach out to our policymakers, the image that they have in their heads is this one on the top. This is what they think we're doing in our clinics. Right. And as a result, state Medicaid programs and our federal insurance programs are specifically writing vitiligo care out of their programs and calling it a cosmetic treatment. And so this has been a subject of a lot of advocacy work, both at the AAD as well as at the Global Vitiligo Foundation. We've had some early success in reversing those decisions in the state of Colorado. This is an ongoing battle. And so to recruit your guys' help in terms of whatever we can do to reach out to our legislators to really advocate and educate with regards to what we are doing for our patients. And this picture on the bottom is the picture that they don't see. And a lot of work has been done in the literature to try to make this argument in terms of editorials and opinion pieces. But most recently, a couple years ago in 2023, Iltifat Hamzavi and a number of collaborators really led this effort to quantify what the burden is to our patients through this Valiant study. 3,500 some patients across the world surveyed. And they were able to demonstrate in terms of medically diagnosed anxiety and depression, roughly 30% of people with anxiety, 25% of people with depression. When they used depression scales to measure the rates of depression within the cohort that they studied, 55% of patients with positive scores on those survey instruments. So it's really hard to argue that a disease with so much burden associated with 55% rate of depression is a cosmetic disease. The response a lot of people will have is, well, this is culturally dependent. And yes, it is true. There are cultures for whom vitiligo is particularly a issue. But as you can see, across the world, the rate of psychiatric comorbidities is much in excess of the background, regardless of where you're from. And so there is truly a renaissance with regards to our understanding of the underlying pathophysiology and immunology that drives vitiligo and really drives home the point that this is a medical condition with established comorbidities, established mechanism, and established therapies that are going to become greater and greater. And so it behooves us to kind of understand how do we best use these tools, much in the similar theme as the earlier discussions today. We are in a wonderful place of we're going to have many options coming up soon. How do I choose amongst this menu of therapies to best improve the quality of life for our patients? And so just to reiterate, this is the picture that is missing from our legislators' eyes that I'm hoping to kind of bring into mind when they think about vitiligo. right? So with regards to the clinical evaluation, broadly speaking, the first step is segmental versus non-segmental. And as you guys all know, perhaps this is more for the trainees in the room. Segmental, kind of a different beast, presents a little bit earlier, tends to be more stable, tends not to be so immunologically driven, whereas non-segmental vitiligo, very much driven by that immunologic pathogenesis. Right. And over the years, there has been a observation that there are clinical signs that will really give you a sense of what is going on with regards to that activity, right? And so I'm going to spend the bulk of my time talking about that immune component because that's where a lot of the new therapeutics are really coming to become available. And so the fundamental first question is this burned out old vitiligo? Is this the damage is done and we're just dealing with the rubble? Or is this actively ongoing inflammation that's still going on within the skin? It's very hard to tell that. To date, the gold standard is ask your patients whether they've seen things changing. The Vita score basically is that, right? The work looking at the validity of that sort of approach demonstrates that you might as well flip a coin. Where it's really hard for patients to know, particularly as they get more and more body surface area involvement. It's really hard for them to tell whether things are changing or whether they're getting new spots. So, what do we have as clinicians? What are the signs that we can look at objectively? And we'll break that down into Kebner phenomenon, trichrome, confetti vitiligo, and inflammatory vitiligo. Kepner phenomenon reported very common, self-reported in up to a third of patients and associated with outcomes that and prognosis that is relevant to us, right? And if you really want to get into the nitty-gritty, you can break down Kebner into several subtypes. I'm going to be talking about Kebner 2B, which is linear organization of depigmentation that is suggestive of an external source of trauma, right? So that's specifically what we're talking about. Trichrome, well recognized for many years, defined as having depigmented spots, regularly pigmented areas, as well as these intermediate hypochromic areas in the skin associated with we're catching the vitiligo at a point where there's this intermediate destruction actively happening in front of us. Within 3 months, that entire area is going to be depigmented. Most recently, confetti-like depigmentation was described as a clinical sign of activity, defined as punctate or little small white macules, usually around a broader area. Amit Pandya, a person who's well known to this group, is the one who first described this in 2015. And it's since become one of the most reliable clinical signs of active inflammation happening in the skin. And then the rarest is inflammatory vitiligo. It's a little bit hard to see in these images, but you get this inflammatory border around the edges where with cross-sliding, you can appreciate that there's actual induration there. And when you do a biopsy in those areas, you can see the pathologic correlates of active inflammation in that vitiligo. So all of these clinical signs that have been described and elucidated over time have been really useful to us as clinicians. Am I going to be treating you as a burned out vitiligo patient where the problem is not the active inflammation? The problem is I've lost my melanocyte precursors and I can't repigment in this area. So I'm thinking more about surgical approaches. Or is there still an active immunologic process going on that we need to shut down with our JAK inhibitors or with our IL-15 inhibition or with any number of other things that are coming down the line? This has been formalized in the past year in a score called the Vitiligo Signs of Activity score, the VSAS. And this looks a little bit complicated, but basically you break down the body into regions that would be intuitive to us as dermatologists. And it's very straightforward. Is there confetti? Is there Kebner? Is there hyperchromic areas in each one of these areas? If there is, you say yes. If there isn't, you say no. Out of these 15 areas, you add them up and you get a score out of 15. Turns out that if you have one sign of activity, the chances of progression in the next 6 to 8 months is 77%. If you have two signs of activity, it bumps up to 90%. And if you have two locations, you go up to 90% or so. So the clinical significance of this VSAS score is quite high in terms of like, what can I see in terms of objective clinical signs that are sitting in front of me? This is a wonderful tool. There is one caveat that absence of signs does not necessarily mean you don't have active vitiligo. So this is one of those like positive is useful, negative, maybe not. 60% of folks with zero signs will have stability. The other way to say it is 40% of people with zero clinical signs will still ultimately declare to be active if you follow them over time looking for expanding or new lesions.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.